in Kiev, in this wonderful, beautiful city. And thank you for the invitation to talk here. And I would like to talk about endoscopic ultrasound. And my first question is, who is using endoscopic ultrasound here? Could you give a sign? Yes, there are some. Many people not. So I will give an overview about endoscopic ultrasound. And we have two difficult types of echoendoscopes, the radial echoendoscopes, and they are fantastic because they give us the possibility to have a 360 degree view. So this makes it very easy to evaluate, for example, the esophagus or the other parts of the GI tract. But this is only a diagnostic tool. In contrast, the linear echoendoscopes, they provide us also with the possibility to do biopsies. So, for example, fine needle aspirations. Or we can use the linear echoendoscopes for interventions. So this is an advantage. It's a little bit more difficult to use those kind of echoendoscopes. The diameter is a little bit larger, and the view, which you can see here on the left side, it's perpendicular to the way of the endoscope. So it makes it a little bit more difficult. What about the perforation risk? Endoscopic ultrasound is a very safe, invasive method. And if we compare the complication risk of endoscopic ultrasound, so diagnostic endoscopic ultrasound, with upper GI endoscopy, so we see it's the same complication risk. Yeah. So the complication risk in diagnostic colonoscopies is higher. And in a national analysis in the States, the mortality was very, very low when analyzing all endoscopic ultrasound examinations in the state. Elubedi is also a very experienced endoscopist. He performed nearly 5,000 examinations, and only in 3 examinations there was a perforation. And what is the risk? The risk using the linear echoendoscope is a risk. In all 3 patients, it was a linear echoendoscope. And the problem can be the intubation. So the hypopharynx can be difficult to pass with the echoendoscope. But echoendoscopic ultrasound offers an excellent possibility to inspect the pancreas. And here I want to show you the classical steps if we do the examination by endoscopic ultrasound, and we have different stations. Stations 1, 2, 3, and 4. So we start here around the gastroesophageal junction. Here. Oops, here. And in this position, we can examine the celiac trunk, superior mesenteric artery, which is seen on the left side. And in the middle, it's a little bit difficult now for you. You can see the pancreas here in the middle. And if you rotate the scope there anti-clockwise, you can even inspect the liver. So if we have a patient with a pancreatic tumor, we always look also to the liver, and sometimes we can identify their metastasis. So it's important. We can also inspect all the other parts of the pancreas, the corpus here in the middle, corpus of the pancreas, and if we rotate it to the spleen, we can also evaluate the cauda, cauda of the pancreas. So this is a very important station to inspect different parts of the pancreas. The station 2 is the duodenal bulb, pylorus, and the antrum, and this is a very important station to look at the pancreatic head and also the common bile duct. And here we are looking for calcification for concrements or stones. And so this is done here, more down here, and here you have a perfect view to the head of the pancreas. And ultimately, station 3 and 4, we insert the echo endoscope more deeply into the duodenum, and there we can evaluate the papilla, the ampullary region, and the uncinate of the pancreas. So, endoscopic ultrasound in idiopathic acute pancreatitis. Does it have a role? And there are early studies, they are 15 years old. They show if you do endoscopic ultrasound in patients who have an idiopathic acute pancreatitis, you don't know why those patients had acute pancreatitis, then in a significant number of them, patients had stones triggering the acute pancreatitis. Microlithiasis, very small concrements, very small stones. Some of them had chronic pancreatitis. Yeah? So this is, I think it's an important examination, especially when we have more than one episode of acute pancreatitis. So if there are recurrent acute pancreatitis 2 or 3 times, doing then an endoscopic ultrasound is really helpful, because those with small stones, there you can perform a cholecystectomy, and then they will probably never again develop an acute pancreatitis. So you can inspect the gallbladder by endoscopic ultrasound, and here you can see sometimes sludge. You can look for the common bile duct and look if there are any stones or sludge. But endoscopic ultrasound is also an interesting method when you're looking for early chronic pancreatitis, because it's very difficult to diagnose early chronic pancreatitis with CT, for example. Yeah? In CT, computer tomography, it's easy if the patient has calcifications, for example, or advanced stages of chronic pancreatitis. But early chronic pancreatitis, it's very difficult. And there are many experts who say this technique is regarded the most sensitive procedure to detect chronic pancreatitis. How does it look like if you use endoscopic ultrasound in patients with chronic pancreatitis? And here you can summarize the parenchymal criteria, the pancreas, and ductal, the pancreatic duct criteria. Yeah? So you can look for small calcifications represented by hyperechoic foci, strands, hyperechoic strands representing fibrosis. You can look for lobularity, or for cysts, calcifications, irregular pancreatic duct. And here on the left side you see some strands, so these white strands here, irregular pancreatic duct here, down here, or here lobularity. So it's like a lobule, the whole pancreas. Other examples, hyperechoic foci, lobularity, or calcifications here on the right side with shadowing. So those are small stones in the pancreas, very typical characteristic for chronic pancreatitis. On the left side, normal pancreas. On the right side, chronic pancreatitis. Irregular pancreas parenchyma, lobularity. And here on the right side, again, a stone here, you can see, sitting in the pancreatic duct with a dorsal, with a shadow here, behind the calcification. But the problem is that there was such a big inter-observer disagreement, or you can also say there was a low inter-observer agreement. So if you ask experts, does this patient have a, does this patient have a chronic pancreatitis? Then there are experts who say, yes, this is clearly a chronic pancreatitis. Others will say, oh, it's probably, or even it's no chronic pancreatitis. So that makes it difficult. So there was an expert group, they met in Rosemont, and they developed the Rosemont criteria, the Rosemont classification, and they strictly defined the parameters or the changes which are found by endoscopic ultrasound. So what is a hyperechoic foci? What is lobularity? Yeah? And their hope was that it's a lot clearer how we judge or evaluate the patients with suspicious chronic pancreatitis. And they did a new classification and according to major criteria, minor criteria, which you can see here on the right side. So even it's consistent with chronic pancreatitis, it's suggestive or indeterminate chronic pancreatitis. And the hope was now everything is a lot clearer. Yeah, but many studies have shown, which were done after the Roseman criteria was established, is it's not easier, it's not clear, and inter-observer agreement is still quite low. So it's still difficult to say is it is really a chronic pancreatitis or not. And one problem is that if you see small changes in the pancreas, you can see the same changes also in patients who are smoking, for example, who don't have a chronic pancreatitis, or drinking alcohol. Yeah? So that makes it difficult. Very sensitive method, but still difficult to really say, is it chronic pancreatitis or not? Very, very sensitive. You can see 2 millimeters changes. A problem for us is also the patients with focal chronic pancreatitis or mass-forming chronic pancreatitis. So no, not the whole pancreas is involved. Yeah? And so there we have the problem to say, is this maybe a pancreatic cancer or is it only chronic pancreatitis? And there is one method I would also show you, elastography. And I think it's an interesting method. So this is a method assessing tissue stiffness based on the concept that diseases coincide with a change of tissue elasticity. So if you have a normal pancreas, it's soft, it's not stiff. If you have a chronic pancreatitis, it's stiffer. And if you have pancreatic cancer, it's a very stiff tumor. Yeah? And this is color-coded. Yeah? So blue is very stiff, and red and green is more soft. And here, for example, you see a patient with pancreatic cancer. On the right side, there's a tumor, and on the left side, it's blue. So it shows us this might be a cancer. Yeah? So here, different patterns. Homogeneous green on the left side, this is normal pancreas. Or homogeneous blue, this is a tumor, malignancy. Or if it's heterogeneous, that it's compatible with chronic pancreatitis. Yeah? And there's a second generation elastography, and now you can measure strain ratios, because it might be a little bit subjective, is it green or is it blue or blue-green, but now you get strain ratios, you get numbers. So is it 1, is it 38, or is it 66? So that makes it more objective. And Julio Iglesias Garcia, who works in Spain, Santiago de Compostela, a fantastic city there, and I visited him also there, and he published this study in 2010, and based on the stiffness of different lesions in the pancreas, and he has shown that neuroendocrine tumors, they are very, very stiff, and as pancreatic cancer also stiff, normal pancreas, a very soft tissue. Yeah? I also would like to talk about cysts, because this is always a problem for us. How do we interpret cystic lesions in the pancreas? Marco Delgado, he will talk about this topic tomorrow as a surgeon, about a therapy of the cysts. I would like to talk about a little bit the morphology of the cysts. Yeah, I think it's important because so many subjects, so many people get nowadays imaging, and so many people we find cystic lesions. And then we have the question, what are we doing with all those patients with cysts? Yeah. And of course the surgeons, they want to do the operations, do the surgery, and they need their time for the surgery. Yeah. So at Stockholm, where I work at the Karolinska Institute, the gastroenterologists, they take part to take care of those patients. We meet them in the outpatient clinic, patients with pancreatic cysts. We are performing the endoscopic ultrasounds, and we have every week a multidisciplinary conference only with patients with pancreatic cysts, every week. So, of course, one of the main cysts you can find is a pseudocyst. associated with acute or chronic pancreatitis. So usually it's a unilocular cyst. It's only one cyst you can see here. A one large cyst, unechogenic, black, yeah. And sometimes those cysts, there is something in the cyst here, yeah. And then you don't know exactly what is this. Is it a tumor? Is it maybe only necrotic material, detritus? What is this? So sometimes it's quite difficult, and then it's quite useful. You can use color Doppler, so you can look for vascularization, yeah? Or you can even use contrast-enhanced ultrasound. So you inject the contrast medium into the vein, and then you can look for the perfusion. So here, no perfusion at all. This is only a cyst, and this is only necrotic material, or fibrin, for example. Yeah. Quite similar are pancreatic cysts, simple cysts. Yeah. It's also unilocular cyst, but they are usually very small, and they are, of course, not associated with pancreatitis. They can be also associated with syndromes like Hippo-Lindau disease or polycystic kidney disease. So small, 5 millimeter, 3 millimeter small cysts, nothing will happen ever. So if you have a patient with a cyst, look, is it a unilocular cyst? Is it only one cyst? Are there many cysts? Or is it a microcystic lesion? Many, many small lesions, many more small cysts. And are there solid components which you have to look for? So this is a very important first step. Yeah? And people say, oh, it's so difficult, there are so many different cysts. But this is analysis of the Massachusetts General Hospital. And if you're looking for the neoplastic cysts, they are basically 3 major cysts. IPNN, intraductal papillary mucinous neoplasm, MCN, mucinous cystic neoplasm, SCN, serous cystic neoplasm. So only 3. It makes it quite easy. So mucinous cystic neoplasm, very briefly. Mostly women have this type of cyst. It's in the corpus and the cauda. It has some bigger cysts, a thick capsule, and no communication with the pancreatic duct. And every 4th is cancer, is malignant. So those are examples of mucinous cystic neoplasm. It looks a little bit like a pseudocyst, huh? Also here. And that makes it difficult. And there are early studies who have shown there are many patients with mucinous cystic neoplasm who are misdiagnosed as a pseudocyst. Yeah? And this is, of course, a very important problem, considering that every 4th can be cancer. Other examples, endoscopic ultrasound here, small cysts here, and here on the right side is a MCN, and here you have even cancer. Important is also to look for mural nodules, because there are some red flag signs. If those patients with MCN have calcifications or nodules, which if you detect them by endoscopic ultrasound or by DT, that could be a sign of malignancy. So there you have to be really careful. This is also an example. It looks a little bit like MCN here, if we go back. Here, quite similar, but the difference is here you have a thick wall, a much thicker wall. This is an example of neuroendocrine tumor, a cystic type of neuroendocrine tumor, and typically those have a thick wall. And very typical for those tumors is also hypervascularized tumor. So if there's suspicion, we sometimes also use contrast-enhanced ultrasound, inject a contrast medium, and then you can see a hyperperfusion, vascularization of the tumor. Some words about IPMN and some examples, how does it look like? So we have main duct IPMN, branch duct IPMN, or combination called mixed duct IPMN. Yeah? And here are examples of endoscopic ultrasound. You have a dilated main pancreatic duct, and then you have those papillary nodules in the pancreatic duct, producing a thick mucus. And on the right side, you have a branch duct IPMN, and maybe you can see here there is a connection between the pancreatic duct on the right side, a small connection, and to the grape-like branch duct IPMN. Yeah. In other examples, here a cystic lesion. This is it's a IPMN on the right side, IPMN. What we also sometimes use is confocal laser endomicroscopy. So it's basically endomicroscopy. You can do this during the during the examination by endoscopy or endoscopic ultrasound. Yeah. And if you put a small probe into a cyst, then you can do the endomicroscopy in the pancreatic cyst. And this is very helpful for diagnosing serious cystic neoplasm, because very typical is the capillary network on the pancreatic cyst wall. So it's a network of many capillaries, and it's perfused there. Yeah. So if you detect this, you can say directly this is serious cystic neoplasm. You can also use it when you perform an ERCP, confocal laser endomicroscopy. So you can go into the pancreatic duct and perform their endomicroscopy. And here you can see those papillary structures, and they are very typical for IPMN. So this is a patient. He had a severe pancreatitis and with a dilated pancreatic duct. And there we did the pancreatoscopy. We put a small probe into the pancreatic duct and we're looking into the pancreatic duct, and there we found some papillary structures here on the right side, B. We even performed endomicroscopy, and again we have seen those papillary structures, and then we took their biopsies, and this showed it was a patient with IPMN. Serious cystic neoplasm, nearly almost benign, most of them are women who have this type of cystic lesion, and it has sometimes a central scar, which you can see here, and it's a microcystic lesion, very small cystic lesions, which you can see here. So if those patients got a CT or MRI, sometimes it doesn't look like a cystic lesion. It looks like a solid tumor, yeah, because those are microscopic, very small cystic lesions. So you can see here. And it's also called honeycomb appearance. Very small cystic lesions. And those are examples of endoscopic ultrasound here. On the first side you could say, oh, this is a tumor. Yeah? But this lesion has many small cysts. And we can, of course, also do fine needle aspirations so that you can aspirate the cyst fluid and analyze it. Or we can also do a fine needle aspiration of the mural of nodules or of the cystic wall, for example. And this gives us also very valuable information. And in Stockholm, we perform those examinations always with a pathologist who comes to our endoscopy room. And when we perform fine needle aspirations, he analyzes exactly after the biopsy, after the fine needle aspiration, the samples, and look at it and say, oh, you have to do another fine needle aspiration. We don't have any cells, for example. So we did also an analysis of nearly 900 examinations with 280 fine needle aspirations. And on the right side it shows if there is a cytologist in the room, the adequacy, sample adequacy, is a lot higher compared to those examinations which were performed without a cytologist in the room. So it can be quite helpful to have the cytologist directly when you perform those examinations. Thank you very much.